Hello, can you hear me?
Hello, Dr. Ahmed. Yes.
And you can see the PowerPoint also?
Yes, doctor.
Okay, thank you. Which are called basal ganglia. We should call them basal nuclei. So sometimes you would hear the term basal nuclei because these are the collection of nuclei which are present at the base of the or on the basal surface of the cerebral cortex. And they are these group of nuclei or ganglia because ganglia is a term when we use the collection of cell bodies outside the central nervous system. But that's why I'm telling you that basal ganglia is a misnomer it should be called as basal nuclei because these are collection of gray matter within the white matter of the cerebral cortex. Like what you saw in the cerebellum, that within the white matter of the cerebellum, there were deep cerebellar nuclei. Similar to that, within the white matter of the cerebral cortex, in the base of the white matter, there are a collection of cell bodies of gray matter, which are called basal ganglia or basal nuclei. So the the objectives of this session is to describe the function of basal ganglia, why it is important to learn about basal ganglia, what is their function. We need to learn about the anatomical location of different basal nuclei. And then the circuitry is the most important part between these basal nuclei because they have a major impact on diseases like Parkinsonism and Huntington's chorea. So we are going to talk about the circuitry of basal nuclei and in relationship to diseases like Parkinsonism and Huntington's disease. The other thing which you should know is that as we are talking still about the motor system, uh, these basal nuclei or basal ganglia are also involved in motor modulation. So there was a role of cerebellum in motor modulation, and today we are going to learn about the role of basal ganglia in motor modulation or modifying the motor response which we have. Although both cerebellum and basal ganglia do not have direct connections with the upper motor neuron or lower motor neuron, but they influence the motor movements. Cerebellum, as we said, was important in terms of getting the sensory input and comparing it with the intentional movement and do the corrections while the movement is going on or the motor response is going on. Basal ganglia, on the other hand, has another role. Basal ganglia has a role in terms of initiation of the movement. For example, when you are at rest, the sensory information is going to your cortex, but at rest, your arms and legs and body parts are not moving. Although the sensory input from the environment is going to the cortex and you have no involuntary movements which are happening. This is because there is a continuous inhibition or tonic inhibition from the basal ganglia to the thalamus and to the cortex so that you do not have involuntary movements at rest. But when you intend to start a movement, the information goes to the basal ganglia, and for that transient period of time, the inhibition from the basal ganglia to the cortex stops so that you can perform a movement. So, if there is a problem with basal ganglia, either you would have excessive inhibition going to the cortex, so it would be very difficult to start the movement, which happens in Parkinsonism, or there would be too less of the inhibition going to the cortex, which will make you to perform involuntary movements at rest, which happens in Huntington's chorea. So we are going to discuss both the problems of basal ganglia. Too much inhibitory discharge, which will make you difficult to start any movement, which happens in Parkinsonism, or you have the other problem, which is if too little of the inhibitory discharge from basal ganglia to the cortex, which results in involuntary movements at rest. So we are going to discuss both issues of basal ganglia, which are characterized as hypokinetic disorders, where it is difficult to start the movement like Parkinsonism, or hyperkinetic disorders where you have excessive movements at rest, which can be characterized as Huntington's chorea or hemibilismus and things like that. So the basal ganglia are four large subcortical nuclei. So basal nuclei or basal ganglia are four large subcortical nuclei which play an important role in the control of the normal voluntary movements. They receive their primary input from the cerebral cortex and send their output to brainstem via thalamus to prefrontal cortex, premotor cortex, and primary motor cortex. So they are receiving the input from the cerebral cortex when you are initiating the movement, and then disinhibiting the cortex to start the movement. So before starting any movement, the cortex need to send information to basal ganglia to stop the inhibitory discharge, which is going to the cortex continuously at rest. The role of basal ganglia in control of voluntary movement emerged by the observations which we have seen in Parkinson's disease and Huntington's disease and certain other movement disorders. That's how we realized that because of the degeneration of neurons within this particular area, we are seeing these clinical findings. And that's how we came up with the role or the function of the basal ganglia. So post-mortem examination of brains of patients with either Parkinson's disease or Huntington disease told us that which set of neurons were degenerated. And that's how we realized that the role of these neurons is in the voluntary, in the control of voluntary movement is this specific role. So there are three characteristics, disturbances, which you see with the problems with the basal ganglia, which include tremors and involuntary movements, changes in muscle tone and posture, and poverty of movement. So if you have a problem in initiating the movement, there will be very difficult to start the movement, which happens usually in Parkinsonism. Or if you have excessive involuntary movement, this is what you see in hyperkinetic disorders like Huntington's disease. Changes in muscle tone and posture can also happen with Parkinsonism because you can have excessive tone or excessive inhibition, which is going to cause changes in muscle tone and posture. So these were the characteristic changes which allow us to think about. And when we looked at the postmortem brains, we started to find out, oh, these are the neurons which get degenerated, and they gave this type of clinical findings. So based on primarily these clinical findings, the basal ganglia were believed to be part of the extrapyramidal system. It was totally distinct from the pyramidal system, which is the corticospinal tract, based on what you see in the clinical. If you have a problem with the corticospinal tract or pyramidal syndrome, you would see paralysis and spasticity. While in the extrapyramidal syndrome, which could be Parkinsonism, could be Huntington's disease, there are involuntary movements like tremors, rigidity, immobility without paralysis. So there might be immobility, but there is no paralysis in the extrapyramidal syndrome. So this was, thought to be totally different from what you see in the pyramidal syndrome, where you have spasticity and paralysis. In extrapyramidal syndrome, you have involuntary movements, rigidity, immobility without any paralysis. The four principal nuclei of the basal ganglia, or the collection of gray matter in the of the basal ganglia, are striatum, which includes caudate, putamen, and nucleus accumbens. And then you have globus pallidus, which has two parts, globus pallidus externa and globus pallidus interna. Substantia nigra you have seen in the midbrain. It has again two parts, substantia nigra reticulata and substantia nigra compacta. These are dopamine containing neurons. And then you have subthalamus. These are the four groups of basal nuclei, which are part of the basal ganglia. Striatum, which includes caudate, putamen, and nucleus accumbens. Globus pallidus, which includes globus pallidus externa and globus pallidus interna. Substantia nigra, which is a dopamine-containing set of neurons in the midbrain. They include substantia nigra reticulata and compacta and subthalamus. And we can divide these nuclei into input and output nuclei. Striatum is the major input, so putamen and caudate are the major input, and globus pallidus interna and substantia nigra reticulata are the major outputs of the basal ganglia. So anything which is coming in from the cortex to the basal ganglia is to striatum, which is caudate and putamen, and then the one which is going out from the basal ganglia to the thalamus would be from either globus pallidus interna or substantia nigra reticulata. So this is the basic game plan. What is happening normally is that there is a continuous inhibitory discharge, GABAergic discharge from basal ganglia to the thalamus. So there is no sensory activation of the cortex. So if you are going to perform a motor movement, the cortex need to send information to basal ganglia, and for a transient period of time when you are performing the motor movement, this tonic inhibitory discharge, which is coming from basal ganglia, stops for a while, which allows the thalamus to activate the cortex, and cortex can perform the movements through corticospinal and corticobulbar tracts. So what you need to understand, what basal ganglia is doing is that it is preventing involuntary movements at rest, because there is a continuous inhibitory discharge from basal ganglia to thalamus. Thalamus cannot activate the cortex to perform any movement. So when the cortex decides to perform a movement, it is going to send excitatory signals to basal ganglia, which will in turn stop the tonic inhibitory discharge for a transient period of time to the thalamus, which will allow the thalamus to activate the motor cortex, and the motor cortex will be able to perform the motor movement. If this tonic inhibitory discharge from basal ganglia, which is continuously coming, is excessive, it would be difficult to start the movement. If it is reduced in a certain disease, then you would have, involuntary movements at rest. So both conditions where either this tonic inhibitory discharge from basal ganglia increases or decreases can result in diseases related to basal ganglia. Now, the major neurotransmitter which you see in the basal ganglia is GABAergic, which is the inhibitory neurotransmitter. So the projection neurons in globus pallidus externa, globus pallidus interna, and substantia nigra reticulata all contain GABAergic neurons, or they release GABA as a neurotransmitter. Thus, the output of basal ganglia, similar to cerebellum, is also inhibitory, and neurons in the substantia nigra compacta contain dopamine, while the interstriatal neurons, which are between caudate and putamen, which are the local circuits, they release the neurotransmitter, which is acetylcholine. So there are three set of neurotransmitter. Major one is GABAergic or GABA, the substantia nigra compacta, which is the dopamine containing neurons, are going to release dopamine, which are in the midbrain, and the intrastriatal neurons, which are between the striatum, which is the putamen and the caudate, are going to release acetylcholine. So these are the three set of neurotransmitters involved in the basal ganglia. Now we start to see where these basal nuclei are located. So we first going to look at the anatomical location of these different basal nuclei. And then we will start to work about the circuitry and which neurotransmitter is released where. And then we'll see in the last piece of this lecture what happens to the circuitry in different diseases. So let's start here. We'll see the caudate nucleus, which is we are going from outside to inside. So the outermost nucleus, which you see a C-shaped nucleus, is called the caudate nucleus. It has a head, body, and tail. And at the end of this nucleus is a large bulging, which is the amygdala. But this is the chordate nucleus, which is a C-shaped nucleus. It has a head, body, and the tail. And it is the outermost, if you start to go uh, uh, from the outside to inside, you would start to see a C-shaped nucleus, which has a head, body, and a tail. This is the chordate nucleus. And then within, just above the midbrain and below the thalamus, you see this collection of nuclei, which are the subthalamus, the substantia nigra. You know that they are present at the level of midbrain, and this is the ventricles, which you see. So let's go around again. So this is the chordate nucleus. In the center of this chordate nucleus, there is this lentiform nucleus. So you see this lens-shaped nucleus, which is called the lentiform. So putamen and globus pallidus together, they form this nucleus which is present within the C of the chordate nucleus, and this is called the lentiform nucleus because it looks like a lens. That's why putamen and globus pallidus are going to form this nucleus which lies within the C of the chordate nucleus, and that is called lentiform. So it is formed of putamen and globus pallidus. Here you are seeing the chordate nucleus again. This is the chordate nucleus. This is the lentiform. And then you see these fibers which are passing between the lentiform on the outer side. On the medial side, there is thalamus. So between the lentiform nucleus and the thalamus, there is these white matter bundles which are passing. And this area, which is lying between the lentiform and the thalamus, is the internal capsule. So you see here, again, now you would see a 3D picture. So this is the lentiform nucleus, which include the globus pallidus and the putamen. This is the chordate nucleus, and this is the thalamus. Between the lentiform and the thalamus, the white matter bundles are passing, and those white matter bundles which are passing between the thalamus and the putamen are the internal capsule. So this is the chordate. Within the C of the chordate, you see the lentiform nucleus. The lentiform nucleus has two parts, putamen and globus pallidus. Putamen is outside, globus pallidus is internally located. And then medially, as you go, you reach the thalamus. Between thalamus and the lentiform nucleus, the bundles of fibers which are going up, they are the fibers, or going down, these are the fibers of internal capsule. So let's make a diagram here. So this is the lentiform nucleus. This is the thalamus. So medially located is thalamus. Laterally located is the lentiform nucleus. Over the top of the lentiform nucleus, you have the chordate nucleus passing. So, and we said the lentiform nucleus has two parts. The green part is the putamen. Green part is the putamen, and then you have globus pallidus, which has globus pallidus externa and globus pallidus interna. So this is globus pallidus interna, globus pallidus externa. This is putamen. Chordate and putamen together, they form the striatum. There is there when you cut the section of the brain, the cord between chordate and the putamen, you would see striations. So chordate and putamen together are called striatum. Then you have globus pallidus. We have already talked about substantia nigra, which is present in the midbrain. Between midbrain and the thalamus, there is subthalamus. So now you are seeing here, this is more of a sagittal view. You see the lentiform nucleus, which has two parts. The outer part is the putamen, medial part is the globus pallidus. Globus pallidus again has two parts. One is the globus pallidus in externa, the other is globus pallidus interna. This is the thalamus, and in between the lentiform and the thalamus, you have the fibers of the internal capsule. So again, you are seeing this is thalamus, globus pallidus interna, externa, putamen, and between them, lentiform nucleus and the thalamus, you see the fibers of the internal capsule. So you have lentiform nucleus, which include putamen and globus pallidus outside, thalamus medially. This is the caudate nucleus. In between the thalamus and the lentiform nucleus, the white matter bundle, which is passing up or going down, is the internal capsule. Now we have a more of a horizontal section of the brain. So this is, cutting the brain like this. So you see this gray matter, which you are seeing here, which is of our interest. This is the head of caudate, and this is the tail of caudate. This is the lentiform nucleus which you are seeing here. This is the lentiform nucleus. Within this lentiform nucleus, the outer part is the putamen, the inner part is globus pallidus. And within the globus pallidus, this is globus pallidus externa, this is the globus pallidus interna. This gray matter which you are seeing here is the thalamus. Between the lentiform nucleus and the thalamus, you are seeing this white matter bundle, which is the internal capsule. The part of the internal capsule which is lying between the head of caudate and the lentiform nucleus is the anterior limb. The part which is lying between the lentiform nucleus and the thalamus is the posterior limb. Where these two parts of the internal capsule are joining is the genu. So these are the parts of the internal capsule. If you see, this is the internal capsule, head of caudate, tail of caudate. This is the lentiform nucleus, which has on the outer side the putamen. On the inner side, you have globus pallidus externa and then interna, and this is thalamus. And because you can see the striation between the putamen and the head of caudate, this area is called the striatum. This is the globus pallidus, which has two parts, as we said, interna, externa. The third set of nuclei of the basal ganglia is substantia nigra, which is present at the midbrain. And between midbrain and the thalamus, the area is called the subthalamus. So these are the four basal nuclei of the basal ganglia. So this is the head of caudate, this is the tail of caudate, this is the lentiform, and then you have two parts of the lentiform, putamen on the outer side, globus pallidus on the inner side, and then globus pallidus is further divided into globus pallidus externa and interna. This is thalamus, and you have the internal capsule in between. This is the anterior limb of the internal capsule. This is the posterior limb of the internal capsule, and this is the genu of the internal capsule. Now, this we have discussed before also, and we would now go into more details about the circuitry of the basal ganglia. What we are saying is that the basal ganglia, from the major output of the basal ganglia is globus pallidus interna and the substantia nigra reticulata, and they are continuously discharging inhibitory discharge to the thalamus at rest. So when you are at rest, the thalamus cannot activate the motor cortex because there is a continuous inhibitory discharge of GABAergic neurons, which is coming from the globus pallidus interna and substantia nigra reticulata, which are inhibiting the thalamus. So thalamus cannot activate the cortex. But when the cortex decides that it has to perform a motor movement, it is going to send an excitatory signal to the striatum. And as we said, striatum is made up of two things, putamen and the caudate. So when the striatum gets activated, it is going to disinhibit the thalamus by removing this tonic inhibitory discharge for a transient period of time on the thalamus. So the thalamus can activate the cortex and motor movement can be performed. So you can see it here. This is the neurons which are of striatum. These are the neurons of globus pallidus. And these are the neurons of the thalamus, and this is the motor cortex. Now, what you are seeing that at rest, these neurons in the globus pallidus, which is the B, are tonically active. So what they are doing, they are continuously inhibiting the thalamus. So thalamus has no activity, and that's why the motor cortex also has no activity. But when the motor cortex decides to to have a motor activity, it is going to excite the striatum. So you start to see, striatum getting activated. Striatum is going to inhibit the globus pallidus transiently. So in this period of time, when the globus pallidus stops its tonic discharge to the thalamus, you would have activity from the thalamus, which will excite the cortex, and then the cortex is going to excite the lower motor neurons to perform a motor activity. So this is the normal route. Whenever at rest, globus pallidus is continuously inhibiting thalamus, and then thalamus cannot excite the cortex. So at rest, you are not performing any movement. But when the cortex decides to perform a movement, it is going to excite the striatum, which will in turn inhibit the globus pallidus transiently, and this will allow the thalamus to get activated, and then the thalamus is going to activate the motor cortex to perform the movement. This is the normal route of basal ganglia. So this is the direct pathway which you see. The cerebral cortex, normally what is happening is that there is a tonic discharge from the globus pallidus interna to the thalamus, and thalamus is not active, so it cannot excite the cortex. But when the cortex decides to activate to perform a movement, it is going to transiently activate the caudate and putamen, which is the striatum, which will transiently inhibit globus pallidus interna. So the tonic discharge, which was going from the globus pallidus interna to the thalamus, will stop for a while, which will activate the cortex, and you would be able to perform the movement. This is the same function which can happen through D1 receptors, which are from the substantia nigra compacta, that they would stimulate D1 receptors in the striatum, which will transiently inhibit the globus pallidus interna. As a result, the tonic inhibition will stop for a while so that the thalamus get activated, and thalamus is going to activate the frontal cortex. Now, there is also an indirect pathway. Now, this indirect pathway, what is happening is that it is going to work through globus pallidus externa. What is globus pallidus externa is doing? Like globus pallidus interna was tonically inhibiting the thalamus, the globus pallidus externa was tonically inhibiting the subthalamus. So it is continuously at rest. Globus pallidus externa is continuously discharging inhibitory signals to subthalamus. So subthalamus cannot excite globus pallidus interna. So the activation of the globus pallidus interna cannot happen. But when the cortex decides to have a movement through the indirect pathway, it is inhibiting the movement. How? Because through these indirect pathway, the cerebral cortex is going to excite the striatum. Striatum is going to transiently inhibit the globus pallidus externa, which is the GPE. So the tonic inhibitory discharge to the subthalamus will stop for a while, which will increase the activation of the subthalamus to globus pallidus interna. And what globus pallidus interna was doing was inhibiting the thalamus. So it was stopping the movement. So through direct pathway, you were activating the movements, while through the indirect pathway, you are inhibiting or inactivating the motor response. So what is this happening? So what you want is fine tuning of your movements. You need precise muscle tone, you need precise movement. So you are activating the muscle movement through the direct pathway, and you are inhibiting the muscle tone and muscle movement through the indirect pathway to fine tune the movements. This again, the indirect pathway also works through the substantia nigra compacta through D2 receptors. So D2 receptors, if the dopamine binds to D2 receptors in the striatum, this will inhibit transiently the globus pallidus externa. So the globus pallidus externa would have less tonic inhibition of subthalamus, and this will result in activation of globus pallidus interna, which will result in inhibition of the thalamus and the poverty or decreased motor movement. So direct pathway will will facilitate movement. Indirect pathway will try to inhibit movement. So this is a fine tuning mechanism which is there in basal ganglia. The direct pathway is facilitating motor response. Indirect pathway is inhibiting motor response. So this is also shown here. So activation of direct pathway disinhibits thalamus, leading to increased thalamocortical activity and increased movement. While the activation of indirect pathway, which is through the striatum to globus pallidus externa, and then globus pallidus externa's tonic inhibition to subthalamus decreases for a while. So subthalamus was able to activate globus pallidus interna, and which will increase its inhibitory response to the thalamus and cortex. So indirect pathway further inhibits thalamocortical neurons and decrease the cortical activity by decreased movement. So these are two pathways are working opposite to each other. So what is happening? Direct pathway is activating motor response, while the indirect pathway is inhibiting the motor response or increasing the inhibitory discharge of globus pallidus interna to the thalamus so that there is decreased motor movement. So this is fine tuning of the movements so that you have precise movements. So you might have the direct pathway working on certain set of muscles, and you might have the indirect pathway affecting the other set of muscles which you don't want to move. That makes the movement much more precise. Now let's see what happens in Parkinsonism. Now, in Parkinsonism, we know that this substantia nigra compacta is affected. So, if this substantia nigra compacta is affected or it is degenerated, it is not producing dopamine. So these dopamine receptors, which are there, D1 receptors in the striatum, which are excitatory. So if you have less dopamine, less excitation of striatum, if you have less excitation of striatum, you cannot inhibit the globus pallidus interna. So if you cannot inhibit the globus pallidus interna, there would be more inhibitory discharge going to the thalamus, and it would be very difficult to start a movement. Similarly, the similar action is happening with D2, because if you cannot inhibit D2 receptors. So the striatum inhibitory response to globus pallidus externa would increase, and as there is would be more increase in the inhibitory response of the striatum to the globus pallidus externa, the tonic inhibition of the globus pallidus externa to subthalamus will decrease. As a result, subthalamus will excite the globus pallidus interna, and there would be more inhibition of the thalamus and the cortex. So both through direct and indirect pathway, the inhibitory flow from the globus pallidus interna to the thalamus would increase in the Parkinson's disease because of lack of dopamine. The dopamine through D1 receptors is excitatory and D2 receptors is inhibitory. But because dopamine is not no more there, neither you are exciting D1 receptors nor you are inhibiting D2 receptors. So both the effects of the direct and indirect pathways would not be there. As a result, there would be the GPI discharge, the discharge from the globus pallidus interna would increase, and as a result, there would be inhibition of the thalamus, and there would be very difficult to start any movement. So if you see here, this is much more clear here. So you have degeneration of these neurons which are projecting into the striatum. So neither you can excite the striatum through the direct pathway through the D1 receptors. So the if there is decreased excitation of the striatum you would not be able to inhibit globus pallidus interna. As a result, there would be more tonic inhibition of the thalamus. On the other hand, if you do not have D2 being inhibited so D2 are inhibited by the dopamine, and if they are not going to inhibit the globus pallidus externa, they would not be able to inhibit the striatum. There would be more inhibitory discharge from the striatum to globus pallidus externa. As a result, the tonic inhibition of the globus pallidus externa to subthalamus will decrease, and subthalamus will excite globus pallidus interna, leading to more inhibitory response to thalamus. So, what you see really in Parkinsonism is poverty of movement. There is hypokinesia because there is too much inhibitory discharge, which is going from the globus pallidus interna to the thalamus, and thus it is very difficult for the motor cortex to initiate the movement. What you find in these people are they have mask-like face, cogwheel type of rigidity, tremors, the stoop posture, and shuffling gait. Their arms are not moving. So those type of things which you are finding because the tonic inhibition of the cortex is so much that it is so difficult to start the movement. Let me see if I can, show you this video of show you the video of Parkinsonism. And can you see this video? Are you able to see this video which I'm showing you? Hello?
Yes, doctor.
Yes,
Okay.
doctor.
So let's see this video. So what you are seeing here is the tremor of Parkinsonism, which is a pill rolling type of tremor. So it's like a pill rolling type of tremor, which is characteristic of Parkinsonism. And then you are going to see this patient which has very difficult time in initiating the movement. You can see a very shuffling type of gait in this individual, in this patient. You see, sorry. So you can see a very shuffling type of gait. Freezing can happen. So there's a period of freezing and then they start to move. But you can still see the arms are not moving as you would see in normal individuals. Initially, the arms are all on the side. So there is a freezing period, shuffling gait, which you would see with the patients with Parkinsonism, and there is no normal arm swing, and which you see with normal people. So they have stoop gait, they have mask-like feces, they have, you see the mask-like feces are there, and then you would see also that they have a pill rolling type of tremor which is at present at rest. So these are the features of the Parkinsonism. So let me go back to my PowerPoint. The second disorder which we are going to discuss is the Huntington's disease. And Huntington's disease is more of a genetic disorder. It runs in families. What you have is, and it happens in young patients, so you would see that it is because of, certain repeats, which you would see in the DNA. And the major problem in Huntington's disease is that the striatum is degenerated. Now, because the striatum is degenerated, the inhibition of the subthalamus, especially through the indirect pathway, because GPE was inhibited by by the striatum, and now there is no more inhibition of the striatum to the GPE, which is the globus pallidus externa. So their tonic inhibitory discharge of the globus pallidus externa is going to increase. And as a result, the excitation of the subthalamus to the GPI would almost finish. So because the subthalamus cannot, excite the GPI, the inhibitory discharge from the GPI to the thalamus will decrease. So at rest, you start to have choreotic movement. So because of the reduced striatal inhibition of the globus pallidus externa, the tonic inhibition of globus pallidus externa to the subthalamus will increase, and subthalamus cannot excite the GPI, which is the globus pallidus interna. So the inhibitory discharge, which is the final output from the GPI to the thalamus, will decrease. And as a result, you start to have excitation at rest and you have choreotic movement at rest. So this is a type of hyperkinetic disorder. What you are seeing here is that the major problem is because you have degeneration of the striatum, the inhibition of the striatum to the globus pallidus externa is going to decrease. As a result, there would be more inhibition of the globus pallidus externa to the subthalamus and to the globus pallidus interna. As a result, the inhibitory discharge from the globus pallidus interna to the thalamus will decrease, and you at rest you are unable to inhibit the thalamus and the cortex. You start to have involuntary movements. We can show you another video later, but you can see this is the degeneration which you are seeing in the head of caudate and the putamen in the Huntington's disease. In Parkinson's disease, you would see the degeneration of dopaminergic neurons which are present in the substantia nigra. So this is what you see on the pathology. Uh, the last one among the hyperkinetic disorders which we are going to discuss is the problem with the subthalamus. You can have an infarct of the subthalamus, and because there is infarct of the subthalamus is unable to excite the globus pallidus interna, and as it is cannot excite the globus pallidus interna, the inhibition from the globus pallidus interna to thalamus will decrease, and there would be excitation of the thalamus, and you have hemibilismus. Half side of the body is going to have these excitatory type of movements or ballistic movements, and that's why it is called hemibilismus, and it happens because of the infarct to the subthalamus, which will reduce the excitation to the GPI. And as there is decreased excitation to the GPI, the tonic inhibitory discharge from the GPI to thalamus will decrease. And as a result, the cortex will get excited and you have ballistic movements of the half side of the body. So this is not a genetic disorder. Huntington's disease is a genetic disorder. This is probably because of an infarct or an insult to the subthalamus, resulting in the destruction of the subthalamus and reduction in the excitatory signals from the subthalamus to the GPI. And as a result, the GPI cannot inhibit thalamus, and you have half side of your body having ballistic movement. That is called hemibilismus. Now, in summary, uh, uh, the basal ganglia selectively facilitate some movements which are through the direct pathway and suppress other movements through the indirect pathway. Compare commands for movements from motor cortices with the proprioceptive impulses from the evolving movements to monitor its consequences. This function is mainly from the cerebellum, but this is the connection of the cerebellum with basal ganglia might be the major issue. But the major function in terms of motor function of basal ganglia is to facilitate certain movements and suppress others, facilitating through direct pathway and inhibiting through indirect pathway. Uh, it do this to finely tune the balance between the three neurotransmitter systems, which are the nigrostriatal dopaminergic system, which are between the substantia nigra and striatum. So those neurons release dopamine. Intrastriatal, which are between putamen and caudate, they release acetylcholine, and striatopallidal, which are between the striatum and globus pallidus, they release GABAergic, they are GABA secreting neurons. And that's why if you see major treatments in Parkinson's disease, you would see, either replacement of dopamine, or you are basically using acetylcholinesterase drugs, which are, going to affect the intrastriatal pathway. So imbalance of these neurotransmitters within this circuitry will cause either hypokinetic disorders or hyperkinetic disorders. And that's why the treatment is also going to be based on these neurotransmitters. Basal ganglia we have talked about in terms of the motor function, but it also has a role in cognition and mood and behavior. So it is not only related with the motor system, there are also extensive connections with the frontal lobe and the limbic areas. That's why it is also related with cognitive functions, executive functions, as well as behavior of people. And you can see that the cognition and effect is impaired in Parkinson's disease in later parts. So you would see in Parkinson's disease early on motor dysfunction, and later part you would see the cognition defects and effects, problems in the effects. While in Huntington's disease, you would find that the behavior problems and the cognition is affected early on, and later on you would find the motor problems in Huntington's disease. The basic output pathways through the basal ganglia links various regions, and as we said, we only talked about the motor ones, which are the skeletomotor loop and oculomotor loop. So the control of facial, limb, and trunk muscles, and control of extraocular muscles. These are the motor effects, but it also have connections with the prefrontal cortex, which is important for cognition and executive function, and with the limbic loop, which is important for the regulation of behavior and emotion. So there are four loops of the basal ganglia. The only one we want you to remember at the moment and in this lecture is the circuitry involved in motor function. But we are telling you that basal ganglia has other functions also. It is involved in cognition and executive function through prefrontal cortex loop, and it is also involved in behavior and regulation of behavior and emotion through limbic loop. Uh, as we have discussed this, these are the four loops, these are the connections. We are not going to go into details. The only thing which you need to know from this slide is there are four loops of basal ganglia: motor loop, oculomotor loop, which is important in movement of the eyes; prefrontal loop, which is important in the executive functions; and limbic loop, which is important in behavior and emotion. That's all what you need to know at this point of time. You don't remember these connections, don't remember them. They are not important. They would not be tested in the exam. The basal ganglia is through the GPI, which is globus pallidus interna, and the substantia nigra reticulata. They are in turn going to anterior nucleus of thalamus. Tomorrow, we are going to talk about the nuclei of the thalamus, so you would know what is ventrolateral and ventroanterior nucleus and the dorsomedial nucleus of the thalamus. These pathways, if you don't remember, don't worry about them. Thank you very much. We can stop here. If you have any questions, I'm happy to answer them. So here, so big inhibitory effect on the cortex is indirectly through thalamus. Yes. So there is a continuous discharge, tonic discharge from globus pallidus interna and substantia nigra reticulata to the thalamus, which is inhibitory. So the thalamus cannot excite the motor cortex because you know all sensory information is going to go to thalamus, which ultimately excites the cortex. So there is no excitation. The thalamus is kept under inhibitory effect of the tonic inhibitory discharge from globus pallidus interna and substantia nigra reticulata at rest. Substantia nigra reticulata does not contain dopaminergic neurons. No, it does not contain dopaminergic neurons. It contains GABAergic neurons. What does the subthalamus do? Subthalamus excites the globus pallidus interna. But it is under tonic inhibition of the globus pallidus externa. GPE is tonically inhibiting subthalamus. When the tonic inhibitory discharge of GPE through the indirect pathway is reduced, then the subthalamus is going to excite GPI, which is the globus pallidus interna, and increase its inhibitory discharge to the thalamus and the cortex. So the indirect pathway is actually suppressing certain movements through the indirect pathway through the subthalamus. What is, yes, 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 yes. Why do we have tremors happening? So we don't know exactly how the tremors happen, but definitely if you have between the direct and indirect pathway, if they are not working precisely, then the tone and the motor activity would not be fine tuned, and then you start to have tremors at rest. Because at rest, you have continuous inhibition of the cortex, so the motor tone is maintained by your reflex arc. But if you start to, have unequal signals coming from both direct and indirect pathway, it might lead to imbalance in tone and leading to tremors. But this is just a hypothesis. There is nothing which we can find in the literature talking about why do we have tremors in terms of the circuitry we can explain. So in both direct and indirect pathway, the dopamine coming from the substantia nigra result in increased motor function. So you should remember that both direct and indirect pathway have opposite role. Direct pathway through D1 receptors is increasing the motor activity, and indirect pathway through D2 receptors is inhibiting the motor activity of certain muscles. So what you are seeing is, because D1 receptors are excitatory, they are going to cause excitation of motor movement or increased motor movement, while D2 receptors, the dopamine acting on the D2 receptors in the striatum, are inhibitory, and they are going to cause inhibition of movement, because that would decrease the inhibition of the GPE. And as the GPE, there is more inhibition of the GPE, there would be, what would happen is that the GPE is the tonic inhibition of the GPE to subthalamus is going to decrease, and the subthalamus response to the GPI would increase, increasing more inhibition. So the response to, as I've said, to direct and indirect pathway is different. D1 receptors are excitatory, D2 receptors are inhibitory. So when you lose dopaminergic neurons in Parkinsonism through both direct and indirect pathway, what is going to have happen is the poverty of movement. You would have excessive subthalamus activation through the indirect pathway, and through the direct pathway there would be less inhibition of GPI, and as there would be less inhibition of GPI, there would be more inhibitory response from GPI to thalamus. Is half side ipsilateral or contralateral? If you are talking about hemibilismus, it would be contralateral. Uh, which activates the substantia nigra. Substantia nigra can get activated directly from the cortex. Why are the tremors in Parkinsonism if there is increased inhibition? So I said it is my hunch. There is nothing written, but this is because of the imbalances between direct and indirect pathway that you might have, tremors in Parkinsonism at rest. But this is just my hunch. We don't know. Anything else which you people want to ask? Okay, if there are no more questions, I would leave this session.